Okay, good afternoon, everybody. I'd like to welcome you to the Geary Institute for Public Policy Research Seminar Series. Today, I'm delighted to welcome Dr. Emma Nicholson, Dr. ThérEØS McDonnell, and Ciara Conlon, who are based at the Centre for Interdisciplinary Research, Education and Innovation in Health Systems, also known as IRIS, at the UCD School of Nursing, Midwifery and Health Systems. So the work that they are going to present today is based on a CUPID COVID-19 project, which is a multi-methods study. They will talk to us about the impact of the COVID-19 pandemic on paediatric emergency department utilization and the healthcare seeking behavior of parents. And again, a reminder just before our seminar starts today is that questions can be directed through the Q&A button and will be dealt with at the end of the seminar when the presentation is over. So without further ado, over to you. Thank you.
Thanks, Sharon, and thanks to the Geary Institute for the chance to share our research, which we're very pleased to be able to do. We belong to, or we're working on a project called CUPID, very romantically labeled project for the month of February. CUPID is an acronym for Children's Unscheduled Primary and Emergency Healthcare in Ireland. So based off that project, we decided that we wanted to contribute to the COVID-19 research agenda and applied for funding, and that's the project we're about to present to you. What we felt that we could actually answer questions that might help understand what's going on in Ireland during the pandemic is as follows. We were asking, what are the changes in the paediatric attendance patterns at emergency departments during the pandemic? And indeed, what are the likely impacts of these changes during and beyond the pandemic? And also, what are the barriers for parents accessing emergency healthcare for their children during the pandemic? Now, we structured our project over 3 different packages, and I'm going to talk to you about the first package, work package 1. And that involves the extraction of data from a number of hospitals, and we look at the change in patterns of attendance at emergency departments by children over the pandemic. Now, work package 2, my colleague Ciara Conlon is going to talk to you about that. She conducted a number of interviews with emergency department staff during the late summer, early autumn period with some very interesting findings. And then the third work package, we conducted a cross-sectional survey of parents in June of last year, and Emma will speak to you about the findings from that survey. So we're not alone in our research, and we have a number of co-investigators. So we have Professor Alish McAuliffe, who's Health Systems UCD. We have doctors based in the hospitals that we work with. So we have Michael Barrett, who's based as a consultant in CHI Conlon, Conor Deasy, who is Temple Street, and Fergal Cummins, who is based in the University or Hospital Limerick. We are also collaborating with Professor Conor Deasy, who is based at Cork University Hospital, and Ciara Martin, who is based in Tallaght. As you can see, a lot of data has come from these hospitals. So there's a list of people there who have worked hard to help organize and extract that data for us. So we're very grateful for the very collaborative and team approach that's gone into producing this piece of research. Okay. So I'm going to talk to you about work package 1, and that's looking at the actual attendance patterns at our emergency departments for children during the pandemic, or certainly today I'm presenting part of the period of the pandemic. So you might ask the question, really what can we add to this that the HSE or the Department of Health don't already know, i.e. don't they pull this information? And the answer is yes, the HSE do collate data on emergency department attendance, but it's a challenging environment in which to pull data because each hospital, a lot of hospitals have different systems, and even within hospitals, there's varying quality of data. So one of the things that they have had a delay, or it isn't currently the case in capturing, is the reason why people turn up at hospitals. So reason for attendance or diagnosis or presenting complaint has only very recently been collated by the HSE. So needless to say, if you're trying to figure out the impact of COVID on emergency department attendance, knowing why people are turning up and indeed who is not turning up is of great interest. So we are working on a project, as I said, called CUPID, and through that project we've been working with 5 hospitals, which represent almost half of the annual public paediatric emergency department attendances by children. And we have been collating a large number of variables at visit level. So we actually have a very large database spanning back to 2013 that we know reasons why people have been turning up at the emergency department. Now, when I say people, I'm talking about children here, and our definition of children is under the age of 16. So my camera is obscuring the slides here a little bit, so I hope you can see them perfectly. So we're working with CHI at Conlon, Tala, Temple Street, the Urgent Care Centre in Conlon. We also have Cork and Limerick University hospitals in our data, and they are all involved in the original CUPID project. So why did we think then we could actually react quickly and respond to this, this funding call? Well, first of all, relationships are extremely important. We were working with consultants in each of these hospitals on an existing project. We already had spec'd out reports and worked with system managers in each of these hospitals and had indeed already extracted data and had built this database. And it's by no means an understatement to say that getting ethics approval can be quite a lengthy process, and we had gotten it from each of these participating hospitals already. So we understood what was involved in getting to that stage. So we felt we were able to respond very quickly to the need to understand what was going on as the pandemic started to unfold. So we applied for this funding in April, and we got funded in the first round of the HRB Rapid Response funding call. So we hit the ground running basically in May. Okay, so what did we actually find? So we're going to just focus on a couple of aspects of the project today, particularly on the data side, because we looked at the data in a number of different ways. And the first thing I'm going to show you is what I think is probably the most interesting. We looked at the reasons why people were attending, again, children were attending the emergency department, and we gathered the information or the attendances into categories that would align to the public health measures that were put in place. Now, by that, what I mean is, for instance, we categorized all attendances under headings such as infectious. So infectious would include presentations that are respiratory, ENT, digestive, and infectious diseases. And these are obviously going to be impacted by measures put in place, such as social distancing, and indeed, as is currently the case, children not mixing because of sports not being in place, and also schools being closed. So the chart to the right-hand side starts at the beginning of 2020. On the top line, the blue line indicates infectious disease type presentations. And indeed, they account for, depending on the time of the year, up to from a third to almost a half of emergency department presentations. So it's a huge part of what hospitals deal with on a daily basis, as I say, in particular in the winter months. The next line down, the green line, relates to trauma or physical activity. So these are your fractures, your lacerations, your sprains, etc. A lot of which will be to do with normal childhood activities, in particular sports. Okay. Then a line that may not be as obvious in colour terms near the end was personal safety. We decided to include a category for that because we were getting feedback from hospitals that they were seeing a lot of poisonings of young children. And by that, I mean, a young child getting hold of a Calpol or a Nurofen. So that was becoming more of a concern for them. And the reason we felt that category was representative of the situation at the time was a lot of parents were working from home and also supervising children at home. So it was a very challenging time, not unlike where we are at the moment. Little did we think we'd be back here. in February. Another category which we looked at was mental health, and of course we were very concerned that children wouldn't be able to access the supports that they needed during the closures of schools, etc. And then another category was medical, which is almost like a catch-all. So some of these could be planned type illnesses in terms of ongoing and needing support, or surprise occurrences like appendicitis. Okay. So just to maybe to make it clear that the biggest category is infectious disease, followed by trauma. And again, trauma at this time of the year, the first 2 months, is relatively low because it gets higher as the year goes on and the weather gets better and sports activities really start to come into play. Okay, so the first case of COVID hits Ireland at the end of February, and we enter into a phase of what was called in public health terms, the containment phase. So what that involved was literally anybody, which was very few numbers at the time, who tested positive for COVID, had to go into isolation, was taken into a hospital room, etc. So what we found there is when we were in that stage, now schools are still open, there was not really much of a change to presentations, okay? But what was also happening was there was a narrative beginning to come through to the public from the press, from the media, very alarming pictures from other countries with regard to hospitals being overwhelmed. And we were literally waiting for some sort of wave to hit this country. And there was a lot of doubt expressed about the ability of our health system to actually cope with this wave. Here's just one quote at the time. Leading cancer doctors warned he does not have faith in the ability of Ireland's health service to cope with a sudden surge of COVID-19 patients. So an insider inside the system is already saying, guys, we're not even going to be able to cope here. So on the 12th of March, our schools closed and we moved into a phase called the delay phase. Our case numbers start going up. And then if we look at the chart to the right hand side here, in the delay phase, which really just involved us trying to ensure our hospital system had capacity. In the delay phase, there's a big change in the nature and the volume of presentations at the emergency department by children. And this was actually also the case in adult presentations as well. So in particular, literally from the day that the school closes, we see that respiratory and trauma presentations just fall off a cliff, no pun intended. And at this stage, the message was very much in the media that, don't come to hospital unless you really, really have to. So difficult to say if the presentations drop solely because there's a drop in the need, because kids are now not in school and sporting activities have finished, and because children aren't mixing, they're not going to be, in a contagious type environment. And this was a message that was on the CHI, the Children's Health Ireland website at the time. So if you had any respiratory symptoms of any nature, most of which could also indicate COVID, this message would be what would basically tell you, don't come into the hospital. So if you're worried that your child has had symptoms of COVID or flu, please stay at home and contact your GP. So it's not really very surprising that parents weren't bringing their children to hospital. Now, that said, the need to attend hospital may well have gone down as well. Okay, again, the narrative of alarm about what was coming down the track was very, very prevalent. Coronavirus Ireland, hospitals braced as 50,000 may need critical care. Okay, so after the delay phase, then we settled into the lockdown, which actually now is known as lockdown 1. Okay, so on the 28th of March, we were all told to work from home. And the chart here at the time shows that the level of attendance in the emergency department remained very low during this time. The only real category that sees a change is in the presentations for trauma. So your fractures, your sprains, your lacerations, etc. So children were at home, schools were still closed, sporting activities weren't going on, but the weather was good. Children were out and about. Now, this is also the period when attendances for these type of reasons are actually at their highest usually. So it's still way, way down, about 40%, 42% down in prior years. during the mitigation phase. So attendances have stayed very depressed. And again, a lot of that is down to perhaps the living conditions that we were living under at that time. And indeed, that is actually still the case. Up to the end of December, all categories are a little bit below prior levels, but the only one that's remained very low is the infectious category. So that's way below prior years at the moment, right up to the end of this year. Okay, so we also then looked at what were called chronic complex conditions, because these are the rarer conditions that are highly dangerous if there's any delay in attendance for these conditions. So we were quite concerned, as was the case in many countries, that some of these children were not actually being brought to the hospital in a timely fashion. Now, looking to see if there's any evidence of delay for chronic complex conditions. So these are conditions such as cystic fibrosis, diabetes, Crohn's disease, and of course, oncology presentations. And many of them will be presenting for the first time. Because there's so few of them, when you're looking for the absence of something, it can be fairly tricky. But we did a very diligent mapping exercise, and we were able to see that these presentations were actually running 45% below prior years in the early part of the year. Indeed, again, showing how few visits there are, there was 153 of these visits, or these types of visits in 2018, 2019, when we averaged the 2 years, and that dropped to 97. So that was concerning. Now, that said, patients with known complex conditions like diabetes may well have been attending clinics more directly than going through the emergency department. So there could have been a little bit of rerouting if they were known patients, but there's certainly a concern that some of these wouldn't have been known and just were not attending on time. And the reason we'd also be concerned that there may have been delayed attendance was the proportion of these visits that ended up in admission, which would be a proxy for severity, actually had increased quite a lot. So almost 90% of these admissions or these attendances ended up being admitted to hospital. The other thing that we then became aware of very quickly was that although mental health attendances were quite low during the initial part of the pandemic, and of course, they are low in number, usually anyway, there seemed to be a pattern over the summer months that these were actually increasing. And you might wonder, well, these are quite young children. What are they actually attending for in terms of mental health? Well, they do present for suicidal ideation, depression, self-harm, eating disorders, psychosis, anxiety, amongst other presentations. So we were also getting feedback from our collaborators who were on the ground in these emergency departments in Dublin and Cork and Limerick. And we also then, through the qualitative work we were doing, we're getting the message back that they were very concerned about what they were seeing in terms of young children presenting with these complaints or these symptoms, and that it was elevated compared to previous years. So we then collaborated with 2 consultant psychiatrists, Professor Fiona McNichols and Dr. Elizabeth Barrett, and took a more forensic look at this. So this colorful chart here, I hope you can see it, has a traffic light system at the top and at the bottom. And what it does is it's looking at presentations for all reasons compared to 2019 by month, and that is the light gray bar, which hangs below the 0% line all the way across. And then the dark gray, almost black bars are mental health attendances. So we go from January through to October in this analysis here. And the traffic lights at the top give you an indication of what kind of public health measures were in place. So green, for instance, was pre-COVID period, not much going on. Amber, we were beginning to ramp up. Red, we were in lockdown. At the bottom here, green shows schools are open, the red shows schools are closed, and blue, schools and hospitals. Or schools are on holiday, sorry. So what we see is, first of all, before COVID hits the health system and hits society at all, mental health attendances were running ahead of last year, the prior year. And that's actually what has been happening for a number of years. Mental health attendances have been increasing year on year for these young children. Then we go into the lockdown period, and the attendances overall drop really, really substantially. And mental health attendances do drop, but not by as much as they do for all the other reasons. We then go into June, early summer, and we see, even though the attendances for all reasons are actually down, mental health attendances start to increase. And they shoot up in these summer months of July and August. July and August, there's actually a school holiday type effect in mental health attendances at emergency departments. They're normally the lowest attendance, those in December. But we found for July and August this year, they just took off. And in fact, the week before the schools opened was the busiest year in the emergency department, or busiest week in the emergency department over this period. Then the children returned to school in September, October, and the rate of mental health attendances at the emergency department stayed very high. Now, this analysis stops in October, but I can tell you the situation actually got worse. And the busiest month on record, according to our records anyway, at these hospitals was actually November. And December was also very busy. So mental health has definitely been the real story in the recent months behind our figures. Now, I don't want to labor on this too much because I want to hand over to my colleagues. I tend to go on a bit. But just to give you some of the figures from a paper that we've written on this. So in January and February, the first column at the top here, or the first kind of pink section, will give you an idea of what kind of presentations, what do they look like in terms of the ages, etc., and where they're coming from. Well, first of all, about 3/4 of presentations are children aged between 12 and 15. So 25% are actually primary school age. 2/3 are girls, and just over half turn up out of hours, which is a concern because the out of hours service for mental health is very poorly funded. And most are not coming through their GP, they're coming through self-referrals. Then we get into the early months of the pandemic, March to June. And what do we see? We see that, yes, there's a drop, but it's not as much as the overall drop in presentations. Again, continued reliance on out of hours, and also we see them coming through as self-referrals. Of course, this is a time when access to a GP was very challenging because GPs had gone to remote consultation, and they'd also were very, very tied up with the whole test and referral process. July to October, we see that presentations overall in that period were 40.7% up on prior years. And again, worrying from a resourcing perspective, very high reliance on out of hours. So, people are bringing their children or they're self-presenting late in the evening at night. I think in actual fact, the busiest time is after 11 o'clock at night. So that gives you an idea of the profile of these presentations. So I'm going to hand over now in a minute and we'll talk about the survey. So just to give you a quick summary, so ED attendance across all categories was down a lot, up to 62% in some categories of presentations. That remained the case as we began to reopen at the end of May, that the incident rate ratio, which is drawn from one of our papers, was 0.58. But a lot of that can be explained by normal living conditions at the time. Kids weren't in school, sports weren't going on, so kids weren't mixing with each other. So there was very little transmission, opportunity for transmission of viral illnesses. Referrals by general practitioners were actually down by 13 percentage points. Again, not surprising because it was very hard to access a GP at that time. And we would have a concern that there was a reduction in presentations for complex chronic conditions. And as I explained to you also, the mental health presentations were cause for a great alarm. So now we're going to move on and talk, Emma's going to talk about the survey of parents that we did, and I'm going to continue to drive.
Great, thanks, Thérèse. So we conducted a survey of parents, as Thérèse said, back in June, which seems like a long time ago now. And really, I suppose the purpose of that was to try and provide some sort of context to understand some of the findings that we found from work package 1 that Thérèse just presented. So when you were seeing these drops, trying to understand something around the decision making and the behaviour that was potentially leading to these drops. beyond some of the points that Thérèse made there, that some of it was to be expected, that there's less respiratory conditions going around, children aren't mixing, they're not, you know, playing sports and getting injured and things like that. So, so really the purpose was, as it says there, to look at avoidance behaviour and hesitancy on the part of parents about accessing healthcare. And we were really focused on 2 specific phases. So we're interested in the lockdown phase, which is now, as we know, now is lockdown 1, or the delay and mitigation phase. And we were interested then as well in phase 1 of reopening, which started to happen around the end of May, early June. And really as well, we were interested in looking at what was potentially contributing to any avoidance or hesitancy that might have been there on the part of the parents. So on to the next slide there, sorry. So yeah, so we surveyed parents of children under the age of 16, so it was a little over 1,000 parents across Ireland, and we collected data just early June, so it was around the June bank holiday, so just as we were entering that phase 1, and our numbers were kind of almost hitting the single digits at this point. So yeah. So the survey itself took about 5 to 10 minutes to complete. We collected, you know, basic demographic information and health information. So we were interested in seeing, were those families with chronic complex conditions more or less likely to be hesitant or to avoid healthcare services. We obviously asked them about their avoidance, you know, if they needed healthcare, whether or not they attended or didn't attend. We were interested then in looking at, you know, how hesitant would they be to attend the GP or the emergency department. And then we were interested in looking at, you know, why, you know, what are the reasons for that potential avoidance or hesitancy. And then we also put in the stress subscale of depression, anxiety and stress scale, just to give us some sort of sense of seeing, you know, was stress a potential contributor to this behavior. So as you can see there, of the 1,000 parents, about 34% of them said that they did require healthcare up to that point during the pandemic. And about 22% of them decided against seeking it, even though they might typically have gone to the GP or gone to the emergency department. And when you look at some of the reasons, sorry, I'm just going to pop back there for a second, Trey, sorry. When you look at some of the reasons as to why they might have, or when you break those 2 groups up, those that attended were a bit more likely to say they were concerned about their child contracting COVID-19. They obviously still attended anyway. And then another group of them did say they felt the service was needed more by others. Whereas those who avoided were more likely to say that they felt the service was needed more by others rather than, but while still having a fear of their child contracting COVID. So we were also interested in, I suppose, where people were getting their information from. There's a lot of them, there still remains to be a lot of misinformation out there about COVID. And then just fully breaking down the different concerns people might have had around accessing healthcare. So promisingly, the vast majority said they got their information from the HSE or government sources. Some said, a small portion, so I think it was around 15 to 20%, said that they got their information from friends or family on social media. And about the same said they got their information from experts on social media. What I mean by experts on social media is doctors and things like that on social media. And then we look at the concerns about accessing healthcare and why they might be concerned. So the vast majority just said that yes, they were afraid of contracting healthcare, and it's important to note they could select more than one because that made sense. It's not there's only one reason that you'd be afraid of or maybe concerned about accessing healthcare, but fear of COVID was the big one. A large proportion said they feared being judged about using the service during an emergency. That kind of links to, I think, previous findings that we've had, we've seen when speaking to parents about accessing healthcare. That concept of this is not really appropriate. Am I doing the right thing? Am I kind of wasting their time? Things like that. And that kind of links then as well to the 20-25% that felt that they felt that the service was needed more by others. And that kind of reflects maybe some of the discourse that Thérèse had mentioned around people saying there'll be 50,000 people who need critical care if COVID gets out of hand. About 18% felt, this was quite interesting, they felt that they believed the government advice was to stay away from health services. As we know, that was never the government advice. Obviously, the government was to stay at home and not to attend work for unless it's an essential service. But it never mentioned that you should stay away from health services if you felt you needed them. But a lot of people did believe that. Some people thought that basically it'd be busy and they'd have to wait too long. And then other issues around, obviously, didn't have access to a car, wanted to avoid public transport and things like that. So there are some of the reasons that they gave as to why they were avoiding health services. And then we asked them on a kind of 5-point scale around how hesitant they would be to attend services. And we broke it up into that lockdown, delay and mitigation phase and phase 1 of reopening. So as you can see, you know, understandably, during lockdown, people were much more likely to report that they would be much more hesitant or somewhat more hesitant. About, you know, 34-35% said they were about the same. And then that kind of flipped on the when we got to phase 1, because I suppose that was at that point we were probably about 2 to 3 months into that, where people were becoming a little bit more used to the used to COVID and used to kind of interacting, I suppose, in this kind of new world. But also the numbers were much lower. So as you can see, people were much less likely to be hesitant to attend a health service at the phase 1 of reopening. So what we did then was we did a series of multinomial regression analyses just to try and see if we could look at what was potentially contributing to this hesitancy. So here are just some of the factors that came up significant in the analysis. So women were much more likely to be hesitant than men. Unsurprisingly, stress levels were also significantly associated with hesitancy. So those who reported mild to moderate stress were twice as likely to report being hesitant. And those with severe or extremely severe levels of stress were 3 times more likely to report being much more hesitant. And then we also looked at that group that I had mentioned there about those who believed the government advice was to stay away from health services. And this group were almost twice as likely to be more hesitant. Just to basically stay away from health services. So potentially that misreading of the public health advice was influencing them there. And we also then looked at regression analyses for during phase 1 of reopening. So that previous one was during the lockdown. So by that point, the gender difference had disappeared. However, once again, stress was a factor, and people with mild to moderate stress levels were 3 times more likely to be hesitant, and those with severe or extremely stress levels were 5 times more likely to be hesitant at phase 1. So that stress kind of still maintaining that hesitancy even during that kind of phase of low cases and when the country was reopening. And then similarly, once again, those who thought that public advice was to stay away were also, once again, at phase 1, still more likely to be hesitant. So given though that finding there, so I might just get you to pop back there, Thérèse, for a second. Yeah, sorry. Given that finding around those people who believed the public health advice was to stay away from health services, we were interested in looking at what was potentially contributing to that. So we did another the logistic regression analyses on that, and we found that really stress was the main factor that was contributing there. And once again, those mild to moderate stress levels were 1.7 more times more likely to believe that public health advice was to stay away, and those with very severe stress were also more likely to believe that public health advice was meant to stay away from health services or avoid health services. So in terms of the survey itself, I mean, some of the key findings that were, I mean, critically that there was a large group of people, so about 22% of people who needed healthcare didn't access it. Now, we didn't ask about why they potentially needed healthcare, because there's too many variables if we were to ask them every potential reason they might need to attend. And critically, there was no real difference between people who had a chronic, or whose children had a chronic health condition and who maybe had a chronic underlying condition in the household. There was no difference there in avoidance or hesitancy. And while it was promising that the vast majority said they used the government and HSE sources, there still potentially was a risk, with that finding around those who believed healthcare or the advice was to stay away from health services, that potentially that the public health advice was being misconstrued. And I think we saw that around kind of end of April, May, when there was a bit of a push from particularly the Irish Medical Organisation, who were saying the emergency departments are open, and if you need to attend, they're there. And in actual fact, they were actually very quiet, particularly in the children's in the paediatric emergency departments, because children were generally not very badly affected by COVID. They weren't. They were actually quite quiet during that phase. And then once again, understandably, stress is a significant driver of hesitancy and around misunderstanding of public health advice. So really what we felt one of the key findings and one of the main messages from this was about it's really important that public health messaging is aware of how, I suppose, is adequately communicated, so they understand that essential health services remain open. And actually, even if you still look at the, you're still seeing people being confused around what you can and can't do. And even when you look at current level 5 restrictions, from what I can see, it doesn't say anything about saying, essential services remain open. And that includes, if you need to go to the GP, if you need to go to the emergency department, you can still attend these services. That still isn't actually clearly stated to parents. So I think that's really important. I suppose making sure that people are aware that the public health messaging can be misconstrued by certain members of the population. So I'll hand over to Ciara now to talk about the interviews. Thank you.
Hi, thanks, Emma. So I'm going to talk to you about the qualitative aspect of the project and the interviews that we carried out with the frontline staff on the ground in the emergency departments. So the aim of this part of the project was to really contextualise the trends in paediatric emergency healthcare utilisation that Thérèse was seeing in the data from the EDs and give a deeper insight into that. And as well as that, we wanted to understand the experiences of working within the restructured health system, you know, from the perspective of the frontline staff. So we carried out 15 semi-structured interviews with healthcare professionals, and they were carried out in between August and October of last year. So we really captured that first wave and towards the end of the summer as well. We had quite an interdisciplinary mix of participants. So the healthcare professionals included emergency medicine clinicians, nursing managerial staff, hospital social workers, and nursing staff. So we had quite a broad perspective there. And we applied thematic analysis to the data in order to identify common themes across the data. So the key themes then that was identified, we sort of structured them under two main headings. So we had attendance patterns and we had structural and process changes. So we had four main themes under the attendance patterns, and I'll go through each one of them in more detail in the next few slides. And as you can see, there's some sub-themes as well under each theme. And the structural and process changes, then we had three main themes relating to that. So you can just move on, please, Thérèse. Maybe just click the next part. Yeah. So the first theme then was decline, delays, and avoidance, changing paediatric presentation. So this really echoed, you know, what we saw in the data, what Thérèse saw in the data, that the clinicians confirmed that there was a huge decline, particularly when schools closed, and the nature of presentations had changed as well. So they said, you know, there was a reduction in the bread and butter of presentations, your viral infections, and so on. And there was a widely noted that there was a rise in mental health presentations, particularly during the summertime. Looking at delaying attendance then, and this was something that we were quite interested in going into the project because it was picked up in other countries. There was a study in Italy that came out about the effects of delaying attendance. And the clinicians in our study did confirm that they saw delayed attendance, that they felt that there was a sense that they were seeing sicker children in a small number of patients. And they stressed that it wasn't widespread, it wasn't all patients. It was a small enough number, but it was significant and it was concerning. So children were presenting with more progressed illnesses. Some examples was diabetic ketoacidosis, meningitis. There was one child who had displayed symptoms for a number of days, and it actually transpired that he'd suffered from a stroke. And again, they had delayed attending due to concerns they held. And so there was worsened outcomes for a certain number of children. There was also, just go back there, Thérèse. Avoidance was identified in children with chronic conditions. So they felt that those children were trying to stay away with the comorbidities. They weren't seeing as many children with chronic conditions. And there was also a sense that families were reluctant to allow support services into the home as well, due to fear of infection. So there was concern expressed that these families were really not receiving the normal support and care that they would, and that there was quite a burden on them at that time. But it was also noted that there was alternative pathways to care implemented, such as virtual clinics and so on, and that may have mitigated the need to present then to the ED. So the next theme then was parental concerns, and they mostly centred on contagion and messaging, and this is really what was feeding those delayed attendance and that avoidance that they were noting. So obviously, fear of COVID was huge. Parents were sort of clinicians got the sense that parents were really pushing their boundaries more at home. They were weighing up the risk of attending the ED, and they saw it as a site of possible infection, and they were weighing up that risk of attending against the severity of the child's illness. And they were really sort of adapting a wait and see approach at home. There was also a sense that they were reacting really well to the infection control measures that had been implemented, and they were really reassured by them. So they reacted quite well once they went into the hospital and saw what was in place, and they felt reassured by that. So public health messaging, and this echoes, what Emma was speaking about earlier, that there was a sense that parents were, taking that message on board, that they were told to cocoon, they were told to stay at home, stay safe was quite a prominent message, and that they felt that if they broke that message, they might put their child at risk. They also believed the hospitals were really busy. There was a lot of media depictions at the time of frontline workers being to the pin of their collar. And parents were coming in. When they were coming in, they were apologising. They were saying, "We didn't want to come. We know you're under a lot of pressure. We don't want to contribute to that burden." And the actual reality wasn't true, because it wasn't actually that busy in paediatric areas. There was a decline, and they weren't that busy. So a lot of clinicians felt that a public communication strategy could really serve to alleviate those concerns and to help to prevent those delays and avoidance. So let the public know about the infection control measures that are in place, that they're not busy, that they're open, and to continue to present. So the third theme was psychosocial impact on children. So a lot of clinicians felt that there was a huge emotional toll on children, and that was manifested in more presentations to the ED for psychosocial presentations. So it was particularly evident in the adolescent population, but it wasn't limited. There were instances of clinicians describing children as young as 8 and 9 attending with panic attacks and anxiety, which they said they typically wouldn't see that. Anxiety related to COVID was highlighted, and children were really concerned about the effect of the pandemic on their family members. They thought that their family members might die, and they were seeing all these images on the TV and stuff. The closure of schools, the lack of recreational activities, was really introducing social isolation to children, and they had a lack of routine, and that was compounding their anxiety and their psychological well-being. Crucially, the disruption of mental health services in the community was really impacting children's health, the clinicians felt, and that was leading to families then presenting in crisis in the ED. They'd gone beyond their ability to cope at home. Next slide, please. So the disrupted access to community healthcare then, and that echoes that last little bit in that slide. There was, disrupted access to primary care. Clinicians felt that parents were left without their normal systems and supports. Parents were describing that they weren't able to get an appointment with their GP, or that they were only having remote consultations, and the GP was either referring them on because they couldn't do a physical examination, or the parents were self-referring because they just weren't, reassured by that remote consultation. Public health nurse visits face-to-face were suspended as well. Some new mothers they felt were left feeling vulnerable. So new mothers were presenting with, or with small infants were presenting with feeding or colic issues that again would usually be picked up in primary care. So this disrupted access to community healthcare really contributed to what clinicians saw as a loss of a safety net, and this was impacting particular cohorts of children. So first of all was children who were attending mental health services before the pandemic, and those services were now disrupted. They couldn't get their appointments, and they were, as one clinician put it, they were falling through the net. There was children with developmental or neurodevelopmental disabilities, so children with autism, for example. They felt they were being also disproportionately affected. So again, they weren't going to their usual special schools or their other community sports, and there may be some unmet needs there. And also children from more vulnerable backgrounds, children who may be at risk of neglect, and that risk may have been heightened during that period. Again, a lack of a safety net. So in schools, teachers would usually be able to pick up on issues, maybe really intense or lice infestations and things like that. Teachers would be able to see that and address those issues, and those children were now out of sight, and that safety net was taken away from them. So moving on to the fifth theme then, and this is related to the reconfiguration of the ED in order to create capacity. So the reconfiguration then was quite rapid and quite continual adaptation of protocols and pathways. So it's quite an iterative process. As one clinician said, in the space of 4 or 5 days, they had to redesign the whole department, the whole way of providing care, and that was quite a fast process. There was a sense that there was a permission to innovate. Like a lot of the clinicians saw the changes as quite positive, and they saw it as sort of an opportunity to really improve the way that they were providing care. They were describing it as innovative, like adaptive. There was a sense of camaraderie and collaboration and so on. And the way in which they described how the care delivery was reconfigured, really displayed agility. So the way in which they were clustering care, for example, they had to reduce the clinical time with the patient, so they were clustering care. They were creating, for one example there was a portable resource trolley created. So rather than bringing the child to the resource area, the resource area was going to the child. So yeah, again, yeah, it seemed really displayed as quite agile. But the changes that had to be implemented was really placing demand on resources. So there was, a need for more isolation, more cubicles, more staff, more space. And some of the clinicians really felt that it laid bare the deficiencies and inefficiencies in the system that were already there. So, the EDs had to expand their footprint in order to create more isolation capacity, and they had to implement new streaming processes. So they zoned the ED, and they had they streamed the patients by any patients that displayed any COVID or potential COVID symptoms from those who didn't, and the more stronger infection control measures. This all created greater demand on staffing levels, and that was something that they really thought needed to be addressed. So the sixth theme then was quality and safety in care delivery processes. So communication challenges came up quite frequently, and particularly in relation to the introduction of PPE, and that was posing challenges to communication. And the clinicians had to come up with new communication mechanisms, both with patients and with children. They felt that face-to-face interaction and putting them at ease and was really important to sort of gain their trust and be able to carry out their examination. And also with their colleagues in care delivery situations, so they couldn't read their facial expressions, and there was sort of they really had to think work around those communication challenges. They also had to work in smaller teams and resuscitation scenarios, and a couple of the clinicians highlighted that there was more potential for errors and sort of interruption to the care delivery, the flow of care to patients. And the final theme then was psychological challenges for staff. The staff really, exhibited, or they described high levels of anxiety and uncertainty. They had reduced social or informal interactions, so they couldn't congregate in their break rooms, and that was most keenly felt when they were faced with adverse outcomes. So if they had a particular adverse outcome, they would usually have a chat with their colleagues and decompress, but they couldn't do that anymore, and that was really affecting them. Particularly at the start of the pandemic, they were quite anxious. They were looking at images coming from Italy. They were saying, like, we didn't know what we were in for here. And they were really, there was a lot of uncertainty. Some of them were redeployed to different hospitals or different areas of the hospital. So it was quite difficult for them to deal with having to work in a new area while under, in a pandemic. And they expressed a lot of concerns about the way in which the pandemic would play out during the winter season as well. And we know that those fears were realised. So I'll just hand you back to Thérṟise, and she will conclude our presentation.
Thanks, Ciara. Yeah, so in conclusion, what we found quite interesting was the various, strands of our project kind of led us to the same conclusion. So the ED data, the survey of parents, and the interviews with frontline staff, that the findings are very, very consistent. So, we felt from these sources, there was clear evidence that some parents did delay attending, seeking healthcare for the children. And very clearly, you know, from staff and parents, that public health messaging is really important, you know, throughout the pandemic. You know, these parents need to know that services are open and safe for their use and for use by their children. Without a doubt, the closure of schools and community supports, for example, the Children and Adolescents Mental Health Service has really had a severe impact on children and their families. And I mean, it is kind of disappointing, you know, that perhaps there wasn't greater foresight in wave 3, given what we've seen in this earlier wave. For these families, you know, and mental health, my goodness, that was definitely the story, particularly of the last few months, and there's real concern that the situation is only going to get worse on that front. So it just remains then for me to thank the parents and obviously the children and the hospital staff. You know, without access to these records and participation in the survey and the interviews, we wouldn't have been able to get these valuable insights. And if you're interested in the research that we have conducted, we have a web page and all our publications and videos, etc., are up there. So do go and have a look. So thank you.